Hello everyone, very good morning. I'm Dr. David Agarwal, and today I'm presenting some glowing secrets about the fundus autofluorescence imaging. We all know, especially in private practice, it's the least used investigation. But when sometimes other investigations are not providing an answer, sometimes the value of autofluorescence still holds very high, that we will discuss in my subsequent slides. So these are the objectives of the day. We will take one by one. So first of all, what is the principle and working behind the FAF? There are some molecules which are we call fluorophores. They absorb the low wavelength light and emit the high wavelength light. We call them fluorophores. Fluorophores are everywhere. They are inside us, they are outside, they are in nature. In our eye, there are some fluorophores like lipofuscin, melanin, rhodopsin, drusen, and pathological lesions like vitelliform lesions. Lipofuscin is the most common one. So lipofuscin is produced by the photoreceptor layer. Actually, it is a debris of photoreceptors which get accumulated in the RPE cells, retinal pigment epithelium. So autofluorescence is nothing but just the density mapping of the lipofuscin in the retinal pigment epithelium. It absorbs blue light, low wavelength light, and emits yellow-green light, that is high wavelength, and its distribution is maximum at the posterior pole, and it gets increased with the age and sometimes in few degenerative changes over the retina. So how a normal FAF image looks? This is a normal FAF image. As you can see, fovea, disc, and the blood vessels. These all are hypoautofluorescent, while the other fundus image is the isoautofluorescent. So why the fovea is hypoautofluorescent? Because fovea lacks that much lipofuscin. It has more lutein, zeaxanthin, and a high concentration of melanin. And for disc lacks retinal pigment epithelium. So no retinal pigment epithelium, no lipofuscin. Then coming to the blood vessels, in blood vessels, the blood column absorbs all the light. It doesn't emit anything. That is why the blood vessels also appear hypoautofluorescent over the FAF image. Now coming to the few FAF imaging systems that are available in the market. They can be of three types, with the spade filter, with confocal laser system, and ultra wide field imaging, as discussed by Dr. Ruchi recently. They have certain advantages, disadvantages. So this is the price range of that machines available in the market. As you can see, Nidec one is the most economical, note financial interest. Now I will discuss some clinical scenarios. See, fundus autofluorescent can be hypoautofluorescent. If it is hyperautofluorescent, it can be because of increased lipofuscin in retinal pigment epithelium, like in Stargardt disease. It can be because of increased other autofluorescent material, like in West vitelliform disease, or maybe due to some window defects. It can be hypoautofluorescent because of reduced epithelial cells, or maybe due to RPE atrophy, like in RPE tear, or due to maybe some blockage by some other pigments, like I already have discussed in fovea case. So now I will take some clinical scenarios. 3 years back, a 38-year-old female visited to our clinic. Chief complaint was transit visual obscuration. She came for second opinion. Diagnosis was already made, papilloedema, MRI was done, everything was normal, and patient was asked for lumbar puncture. So this was the fundus photo of that lady. Same clinical picture was there in other eye. So when we have done the fundus autofluorescence, so this was the picture. Beautiful nodular hyperautofluorescent lesions was there over the disc. To confirm our diagnosis, we have done the B scan, and in B scan we have seen this hyper-reflective patch over the optic nerve head. So the diagnosis is just get shifted from papilloedema to optic disc drusen, very benign lesions. Nothing to do, just observe. Just for information, this is how the papilloedema or disc edema looks in the autofluorescent imaging system. Now coming to the second case, a young male was seen by a fellow and the diagnosis was made dry ARMD. This was the fundus photo and this was the autofluorescent image. There were hyper-reflective flex-like lesions seen around the posterior pole. Typical, you can see peripapillary atrophy and hypoautofluorescent patch over the fovea, which denotes the foveal atrophy. So it is a typical Stargardt disease, or we can say fundus flabimaculatus. See, drusens can also be hyperautofluorescent, but it depends upon the composition, and second thing, they are not as bright as flex in the Stargardt disease. Now this case is seen by my senior. Actually, it is not my case. See, these two photos are taken 4 years apart. The above picture, it is a case of geographic atrophy post dry ARMD. Patient in above picture, the vision is 6/60, and in below picture, the vision is finger counting at 2 meters. We have done the OCT as the vision is declining so faster. the vision is declining, but the OCT picture is totally similar. So we do not have any answer. We have done the autofluorescent and the answer was where there. The geographical atrophy size increased by two folds in that 4 years. That is why based on the autofluorescence and based on the shape of geographical atrophy, a classification was also given. And it is seen that the diffuse one and the banded one has the worst prognosis among the geographical atrophies. Now this is the interesting one. A young female referred by a physician because she has SLE. She was on a hydroxychloroquine since 18 months and fundus examination was done. It's almost within normal limits. HVF was not that much accurate, but not it was almost normal. And then the OCT was done. In OCT, temporal to fovea, we have seen there is approximation of the RPE and photoreceptor layer. Autofluorescence was done and we have seen this hyperautofluorescent patch over the parafoveal ring. So this is a hyperautofluorescent, which is the very early sign of the HCQ toxicity. Multifocal ERG was done in this case, the diagnosis was confirmed and the patient was sent back to the physician to change the drug or to stop the drug. Whenever you see any HCQ toxicity case in your OPD, immediately stop the drug because even after stopping the drug toxicity keeps on coming in the next few months. So this is the very common case we are all seeing in our daily OPD, chronic CSER, and these are gravitational tracts. If we are doing autofluorescent in these type of cases, if the gravitational tracts are hypoautofluorescent, so these are the inactive one, RP is already dead. But if still there are hyperautofluorescent patches there, maybe active leak is still there, you can send the patient for FFA and you can laser that leak later. Now this is the most common use of the FAF in institutions. Even in some institutions, it is practiced to send the choroiditis patients for FAF on each and every visit of follow-up. Because to see the reactivation clinically on fundus examination, it's very difficult. And as you can see in this picture, there are few lesions superior to fovea, superior to disc, and these are the hypoautofluorescent lesions. They are inactive ones. And there are few lesions which are new appearing, just temporal to fovea. They are the new lesions and they are active one. So just after this picture, you can determine that it's time to step up the steroids or to start the immunosuppressants. Now last but not the least, 15-month-old female, there is history of seizure and limb weakness, came for ophthalmic examination. There is a bilateral cherry red spot was there. As Dr. Gori discussed, this picture was very difficult to take, but the baby has limb weakness, so we were successful in this. Bilateral cherry red spot was there. But when we have done the autofluorescence, we have seen that there is patch of hyperautofluorescence around the fovea. Usually in CRAO, this patch is hypoautofluorescent, that is black. So the presumptive diagnosis of lysosomal storage disorder was made. Patient was sent back to pediatrician. Pediatrician has sent the patient for genomic sequence and patient came positive for Tay-Sachs disease. This case we published in BMJ case court and European Vitreoretina Society. And as we all know, in Tay-Sachs disease, the life expectancy is 5 to 6 years only. So after all this, is in my retina clinic, is having a FAF worth it? Yes, it has certain limitations, cost, limited penetration, artifacts. But if your retina practice is little bit inclined towards the uveitis, dystrophy cases, degeneration cases, or oncology side, FAF is the investigation, non-invasive investigation for your retina clinic. So thank you. Thanks to Dr. Ruchi for providing me this opportunity. Thanks to Dr. Vikas Mittal and thanks to my alma mater, LV Prasad Eye Institute.
What is the status of lead-free fundus photography?